At the start of any clinical shift, a nurse is hit with an overwhelming influx of patient information. Blood pressure readings, pain scales, laboratory results, and emotional distress signals all arrive simultaneously. While an isolated reading, like a heart rate of 120, is an objective fact, its clinical significance depends on whether it follows a fall or occurs during sleep. Synthesizing these disparate variables into a prioritized strategy requires an organized framework. To manage this complexity, healthcare relies on the comprehensive nursing care plan. As we see here, the care plan requires active, ongoing documentation at the bedside. This roadmap evolves through constant collaboration with the multidisciplinary team to document the patient's physical, emotional, and cultural needs. This roadmap is built using a specific problem-solving algorithm known as the NANDA nursing process. The algorithm operates through 5 interrelated components: assessment, diagnosis, planning, implementation, and evaluation. By applying these steps, nurses transform raw, multi-system data into a targeted, legally rigorous clinical strategy. We can see this algorithm in practice by examining a specific clinical subject, Mrs. Eleanor Green, an 84-year-old female who is transitioning into care due to a rapid functional decline. Her medical history presents multiple intersecting variables. She manages hypertension, type 2 diabetes, osteoarthritis, and mild cognitive impairment. These chronic conditions have been complicated by 2 acute triggers: a recent hospitalization for a severe urinary tract infection and a history of falls over the last month. Alongside her physical decline, Mrs. Green faces compounding psychosocial challenges. Her family lives interstate, limiting local support, and her resulting isolation has led to documented symptoms of mild depression. The immediate clinical tension lies in prioritization. A nurse must determine which of these physical and social deficits requires the most urgent intervention. Resolving this complex web of deficits requires the rigid application of the NANDA algorithm, and that begins by establishing a comprehensive baseline. Step 1 of the NANDA process is assessment. This is the deliberate, systematic collection of baseline data. A patient's condition is multifaceted, so data must be gathered from a wide array of sources, including direct patient interaction, conducting thorough family interviews, and reviewing existing medical records. Once gathered, clinical practice requires this information to be split into 2 distinct categories: subjective and objective data. We organize her assessment into 2 columns. Subjective data are internal perceptions: 5 out of 10 knee pain, skipped meals, and deep isolation. Objective data are measurable facts: blood pressure 145/90, 3 kilogram weight loss, sacral redness, and an MMSE score of 22. Without this complete, factual, and legally documented baseline, any subsequent nursing intervention lacks a necessary evidentiary foundation. With the baseline established, we move to step 2, diagnosis and data analysis. This is the moment raw observation is translated into active clinical judgment. The nurse looks for patterns, connecting subjective and objective columns to identify health risks. Connecting her 3 kilogram weight loss with skipped meals establishes a diagnosis: malnutrition risk. Connecting her weak mobility with sacral redness identifies a severe pressure injury risk. The nursing diagnosis serves as a conceptual bridge, linking raw patient data directly to actionable care planning. Step 3 is planning. Here, the nurse and the patient collaboratively establish goals aimed at resolving the diagnoses we just identified. Not all risks carry the same weight. Goals must be systematically prioritized based on immediate client safety and physiological urgency. This infographic outlines the specific framework required to write effective clinical goals. The acronym demands that goals be specific, measurable, attainable, relevant, and timely. Consider a generic goal for Mrs. Green's malnutrition risk: improve nutrition. This phrasing fails the SMART criteria because it lacks a clear timeline and offers no measurable threshold to determine if the goal was achieved. We must revise this into a correct SMART format. Patient will consume 75% of provided high-protein meals over the next 48 hours. A perfectly defined SMART goal provides an exact target. It ensures the entire multidisciplinary team knows exactly what clinical success looks like. We then arrive at step 4, implementation. This is where the theoretical care plan is actively put into physical operation. Implementation involves a broad spectrum of clinical activities, ranging from technical procedures to psychological support and patient education. Interventions are broken down into categories. They include direct care, like managing wounds, and assistance, which covers helping Mrs. Green with bathing and dressing. It also requires collaboration, such as executing the recommendations of a referred dietitian, and continuous observation, which means rigorously recording vital signs and updated pain scores. Implementation is highly dynamic. The nurse must constantly adapt these actions as the patient's physiological condition changes throughout the shift. This brings us to the fifth and final component of the NANDA process, evaluation. Evaluation determines if Mrs. Green actually achieved the defined SMART goals within the strict 48-hour timeframe we set. The nurse must look at the data objectively to assess whether the patient's condition has improved, deteriorated, or remained entirely unchanged. The nursing process functions as a continuous, repeating cycle. If an intervention fails, or if a patient's condition shifts, this feedback loop immediately triggers a new assessment, forcing the nurse to modify the care plan. To guarantee patient safety, every single decision made within this cycle must be rooted in evidence-based care. This means integrating the best available peer-reviewed research, the nurse's clinical expertise, and the patient's own cultural and personal preferences. Finally, we must look at how this process is recorded, the documentation guidelines. Documentation is a strict legal mandate. Notes must be written contemporaneously as events occur, presented sequentially, remain purely objective, and utilize precise professional terminology. The comprehensive care plan provides the definitive legal and clinical record of a patient's journey to recovery.